We hope that you enjoyed this video on supporting type 2 diabetes remotely during COVID-19. Please share your thoughts in the comments and subscribe in order to make sure that you don't miss any new content that we upload. It is now my pleasure to introduce your webinar leaders, Naresh, Kanumilli and Nicola Milne.
Hello everybody, my name is Naresh Kanumilli. I'm a community diabetes consultant and also a GP in Manchester. And along with me is Nicola Milne, Queen's nurse no less. She's going to be along with me, and we're going to hopefully talk to you about the practicalities of supporting people with type 2 diabetes during COVID-19. Important caveat here is it's a fast changing situation, it's very dynamic. So some of the stuff that we're going to be talking about today may well change tomorrow, but hopefully you'll keep abreast of what's happening in the news at the moment. These are our disclosures.
Thank you for the introduction, Naresh. So we know that people living with diabetes face a significantly higher risk of adverse outcomes with COVID-19. And we're really grateful to NHS England for producing some data just last week. So where you're saying it is a fast evolving picture, it truly is. And there's a group of leading healthcare professionals in diabetes who have looked at the data relating to COVID-19. And the data is showing us that there is a higher risk of developing complications with type 1 as opposed to type 2 diabetes. But overall, and this will be evident in the next slide that we show, the strongest risk factor for adverse outcomes with the virus is actually age. Higher blood glucose levels and obesity are also linked to higher risk, but conversely, too tight a glycemic control or a low BMI, so under 18.5, is also associated with increased risk. And in both type 1 and type 2 diabetes, men, particularly people of Black or Asian ethnicity, and people living in those more deprived communities were at higher risk. And again, in both type 1 and type 2 diabetes, those people with pre-existing kidney disease, heart failure, and previous stroke were also at higher risk.
I agree with you, Nikki. This is very interesting data that's come out. And like you say, it's very dynamic as well, what's happening now. But also, if you look at this group of patients or persons with diabetes, you find these are actually the population that you would normally see. And you can see that the high risk ones, which you already know about, but what we're trying to say is within this group, your risk of developing adverse events is higher if you have these risk factors as well as get coronavirus. So,
and I think it was 1 in 3 cases where people had adverse outcomes actually were people with diabetes.
That's a phenomenal number. So it almost gives us a reason to actually actively look for these groups of persons with diabetes.
And as I mentioned, I said that we had a slide which was going to follow on, which just showed what that risk was with increase in age. The top line, the red line, is actually type 1 diabetes. The middle line, the blue one, is type 2 diabetes, and the black one is the general population. So you can see how the risk escalates with advancing age.
And particularly if you look at the type 2 line, which is in blue, if you look at it from the increase, it's almost a 600-fold increase as you get older, from over 40 to about over 80. So again, it's just saying that age seems to be a really huge factor determining adverse outcomes with adverse outcomes of coronary disease.
And of course, we know that there's been a lot of incidents in care homes, and it's good that we're now seeing position statements and advice and guidance in not only assessing frailty, but also in how we should be managing people in care homes who have diabetes.
So we just looked at the high-risk groups, and as the data suggests, older people, I mean, age over 80, and I mean, as you get older, the risks are higher, not age over 80, but as you get older. And the main population, particularly Blacks and Asians, the Black people were more at developing adverse outcomes. Obesity, the data again showed there was a nadir around 25 to 29, and obviously if you're a high BMI, your risks are higher, and a lower BMI population is insane. Poor glycemic control, you talked about that. Chronic kidney disease, again, we talked about the worsening outcomes with people with low eGFRs. Heart failure and stroke were particularly interesting in the sense that just those two categories showed a higher risk among these populations. And the vulnerable, obviously, again, elderly and the care home populations were, again, affected quite dramatically. And as you can see with the numbers that were coming out, the more they calculated the people in the care home, the deaths, the numbers were much higher.
And it's interesting, isn't it? Because I look at who are in these high risk groups, and I'm actually wondering who is in a low risk group, who we don't need to see or we don't need to intensivise with.
Absolutely. So it begs the question, like you say, who is the low risk group here?
Our normal populations. Yeah.
Exactly. So this is a cartoon just telling you, Grandpa, tell us again the story of what life was like before COVID-19. I mean, I put this up not to just give you a doomsday scenario of what's going to happen later, but I think as we'll talk about it later, there are opportunities for us about improving care. It doesn't have to be like this, and we can probably not go back to the way we were practicing, but I think we can look at a better way of practicing.
So we have got challenges. So we know that we are in lockdown, so it is difficult to work the way that we have done doing face-to-face consultations. And I think we've also got this fear factor now as well, because people have been in lockdown and have been staying at home and told to socially distance. I think there is that fear now of actually coming to a GP practice or coming into a hospital setting. And there's also fear for us as healthcare professionals as well, I feel, in that we may feel uneasy about seeing huge volumes of people. We need to make sure we've got enough time in between consultations to adequately clean our areas. And we can certainly say that it's a very tempting thought to have a little bit of inertia. So certainly when lockdown started, you might have been thinking, well, let's just delay that insulin start, or let's just give them another 3 months to see if things will improve. But now that we're starting to see that actually we're probably going to be living with these sort of conditions for a while, certainly until we get a vaccine, we can't really have that inertia, because we know unless we achieve those good glycemic controls, that we look at it, helping people to lose weight, manage the chronic kidney disease, actually we're just going to leave people vulnerable and at higher risk. And we have talked about the challenges with our elderly population. We need to be really proactive with those that have been newly diagnosed with diabetes. And anecdotally, we are hearing more new diagnoses of type 1 diabetes. We haven't got data to substantiate that. But it's very important that we get that early legacy effect in with people that have been newly diagnosed, when it may be challenging to actually see them in practice.
I completely agree. I mean, primary care is not adverse to challenges, but I think this is slightly different in that sense. But I think we have risen to the challenge, and I think obviously all of you guys are heroes out there and just trying to face up to the problems amongst all this lockdown and etc. And like Nikki said, there is fear for healthcare professionals, because you're human beings. After all, you have families at home. You want to try and protect everything, and you need to balance the risks and the benefits of everything that we're doing at the moment. And particularly, I agree with you, Nikki. New patients, new diagnosis. How are we going to manage that? That's a big challenge.
But I think it's also really important we talk about the opportunities that now lie before us. So technology, we've struggled, haven't we, to get technology. We have lots of barriers to using technology within the NHS. And we've seen this acceleration now that we can do video consultations, we can use more online resources and technology apps. And that's really helping with education. So we've got structured education online. Desmond, for example, are offering that opportunity for people with type 2 diabetes. There's even group consultations online. And that's really helping people who may also be socially isolated. We forget what a big problem loneliness is for our cohorts. So where people can come together to do great, group things. And it's also an opportunity to upskill, isn't it? So certainly within the community service, we've found that, particularly in the early days where people were falling unwell themselves, and we had the shielded group as well, the normal GP or practice nurse that might have normally done diabetes wasn't there. So other clinicians were having to upskill quite quickly. So I think that there's been lots of opportunity for that.
Absolutely. I mean, I'm a kind of a glass half full person. So I'm looking upon this as an opportunity to use technology to its best ability. I mean, you know that I've been trying to get technology into our side of NHS for the past 16 years, and suddenly, now that the pandemic has arrived, all the red tape has disappeared, everybody, let's use technology. And I think using it for these things that you mentioned, education, upskilling, and providing reassurance, not just to the person with diabetes, but also to the healthcare professional, saying, well, actually, we are here, we are accessible, the specialists are accessible, we can get the information without having to travel. And then again, we talked about education for the people who actually are workers. You know, what was the attendance rate of structured education? Very minimal. I mean, there could be numerous reasons, but one of them could be, well, it's when I'm working, my employer is not going to give me time. Well, actually, we can give you some education at a time that's convenient for you. So I think opportunities, a lot of them.
Most definitely, and interestingly, we're having conversations with people who have maybe we've not seen for about 3 years because they've been too busy with work, they've had other priorities, and now they're managing to find that time to invest in the self-management of the diabetes. So without doubt, and also people who are housebound, who have transport difficulties coming in, this is great now that we've got this support to do remote consultations.
Fantastic. Can you just tell us about this document that's come out only a couple of days ago, Nikki, about remote diabetes management, and just take us through a little bit of that, and we can...
Yeah, so I'm not expecting anybody to be able to read the fine details on this, and actually it's a 3-page document, but I wanted to put it in just to illustrate the fact that it is as a flow chart, as a process. And this was actually really hot off the press. So it was published yesterday by 2 of my colleagues, Pam Brown and Jane Diggle, who are editors for the Journal of Diabetes and Primary Care. And this is all about how to undertake a remote diabetes review. Now, it must be stressed that this is a live document and it may be subject to change. And certainly there has been some discussion about what does glycemic control.
True.
If you look at the NHS data, it's saying anything from 58 upwards, and 86 and above is where you get your quadrupling of the risk factors. But in the document, it's saying above 75.
So my view on that is individualizing the target. I agree that the higher HbA1c, the more your risk of developing adverse outcomes, but you've got to balance that with how you're treating the person in front of you based on the frailty, etc., and making sure you reach the optimal target for them. But obviously, you're managing all the other risk factors as well, blood pressure, lipids, and all those things.
Yeah, and I think that, I've sent this document out across Manchester this morning, and I've just added the caveat that it's important to use this as a template, but that practice need to make individualised decisions based on what their specific cohort is and actually what their workload capacity is as well.
Absolutely. So one of the benefits of this document is it gives you a template, just like it's on your computer, that you can work your way, you don't miss anything, and then also the person with diabetes feels reassured that actually you've tackled all the topics that you would have normally done on a face-to-face consultation. It brings forward what you might need in order to do a face-to-face consultation at a later stage.
I think there's lots of useful, it's really well referenced, so it brings you into lots of useful resources, and there's lots of little tips about how we can overcome some of the barriers and challenges.
As you can see, the slides are going to be available to you guys post the webcast. So, and also there's a link on there so you can access the articles as well. So don't bother straining your eyes too much to read this.
Definitely not.
Now, when we're looking at remote diabetes reviews, and a lot of this is covered in the previous slide, and what we generally look at, what's an annual review constitute, and these are some of the major things that we look at: blood pressure, lipids, HbA1c, renal. And feet will come on to in a minute, as well as the eyes. And one of the things we tend to miss out is about mental health. So blood pressure, again, the advice is home blood pressure monitoring. He was talking to me earlier today about blood pressure monitoring at home.
But very important that somebody's using a machine that's reliable, one that's calibrated. And the British Heart Foundation, they have an excellent resource on their website which lists the ones that they would recommend for somebody doing home blood pressure monitoring. And I think that's important. We don't want to be making decisions based on a machine that might not be working properly. Yeah. It's a little bit tricky when you're trying to titrate up, for example, the ACE inhibitor, so that might be a little bit difficult. We need to look at how we might get those U's and E's done. But I'd say for lipids, I think that if somebody's on a statin and their lipid profile has been very stable, that's maybe not an urgent issue. But for those that are newly diagnosed, we know the massive importance of getting the lipids right, getting the blood pressure right, and the HbA1c right early. So for those persons, we should be, we can still do that QRIS remotely. HbA1c can be tricky. Certainly practices now are operating cold sites where people can come in to have their bloods done. Some people are doing drive-throughs, aren't they?
Absolutely.
Yeah, so that can be done. But we are experiencing that some people have got that fear and they're not wanting to come in. And in those cases, or where we think that they're, that it's unsuitable, or if they're in that highly vulnerable, that shielded group, then it might be possible that we can look at using a blood glucometer to assess their glycemic control. And in some cases now, we're using it in medications where we wouldn't normally. So normally we'd give it to somebody who was on insulin or a sulfonylurea. But we are now handing them out if we need to assess the effectiveness of other medications. We've done a couple of doorstop drop-offs of meters, and we have arranged with some local pharmacies to keep some meters in stock as well. Yeah,
you are currently the meter maid for Manchester, aren't you?
Manchester, yeah.
So one of the things, with regards to HbA1c technology is developing, so you may be able to do quick on-the-spot tests for HbA1c that might be happening in the near future. Feet we'll talk about in a minute, and again, I agree with you. The previous guidance on doing remote consultations gives you some advice on who the persons you need to see within 3 months, 6 months, and who you need to see face to face. So it's worthwhile looking at that and just making an assessment of who you need to be seeing and at what stage.
And I think it's good as well to pick up the people you've not seen for over a year,
absolutely.
Because they might now be at home. You might be able to catch them in and do those reviews. I think it's important to let people know that certainly the urgent eye work, retinopathy work is still taking place. I've had a number of phone calls to people who thought GP surgeries were just closed. So I think it's important that we let them know that services are open.
Well, that is important. I think a lot of practices have sent out messages to their patients in general, just saying, well, actually, we are open for business. Please ring, ask for advice, etc., etc.
Mental health and emotional health. I mean, it's something that I think is generally overlooked in a diabetes review, but now more than ever, it's really important that we're addressing this. And it's important that we're signposting, that, just have that awareness, ask those questions and know what's available locally. So certainly twice a month at the moment, I'm receiving some great information from my wider community groups telling me about specific support groups, culturally sensitive. I'm talking about the BAME population. So this is a thing that should be asked.
Yeah, you're completely right. I think you need to be aware of what's available, especially if you're going to do something remotely. Who can you point them to try and get some help and support? And there's lots available at the moment. Councils are supporting lots of lonely people. Yeah, let's talk about the feet. This is one thing that is everybody's struggling with. How do you assess feet?
Feet, yeah. And it's great now where we have got those video consultations. And Diabetes UK have done the touch toes test, which helps people look at sensitivity in the feet. And on the other side is an example of a questionnaire which has been devised by one of the practices that I work with, and that's been going out via text message and letter to people living with diabetes. And I think as much as anything, it just reminds people to actually look at their feet, make sure that they are caring for them. And again, it's clearly saying that if they've got any concerns, then to contact the surgery. And we've worked very well with the multidisciplinary foot teams. They're doing video consultations. We've been able to send them photographs of feet, and they are still operating and seeing people face to face. And this is really important to get that message out there.
I think there are lots of areas also looking at different ways of managing foot problems, in a red, amber, green fashion. So green, obviously, contact a lot of dietary, and red is go to hospital. So, but all that involves a lot of education for the person with diabetes, just so they're confident about and feel reassured that there is support out there for them.
And I think this is, where we were talking about clinical inertia. I just wanted to put this in because, sometimes it can just feel overwhelming thinking, how am I going to remotely start somebody on injectable therapies? And certainly this information from Injection Technique Matters, which is on the Trend website. There's some excellent resources here, and there's some great YouTube videos which our people with diabetes can watch, and then they can learn to do their injections. And actually through the video, and we can actually watch them doing the injections live now, and make sure the injection technique is there. And certainly I've done one at 6 o'clock on a Saturday evening, and it was a lady who's got locked down here travelling over from India. And we couldn't work out what was the problem, why she couldn't use her insulin pen. She'd been on insulin for a while, but that was because she was prescribed cartridges but no pen device to put the cartridges in. So when we could actually visually see that, we could understand what the problem was.
I agree, Nicola. I mean, these are all anecdotes, but these are real people. And I think if technology helps clear some doubts, make the right decisions, I think you should use it. And I think it's quite beneficial to do that. And having resources such as this to hand that you can use with persons with diabetes when you're initiating therapy helps the person, improves outcomes, reduces inertia as well. Yes.
Yeah, and also make use of all your teams. So we had an issue on a bank holiday, actually over the Easter bank holiday, where somebody post-discharge was needing increasing volumes of insulin with no impact on the blood glucose levels. And we were able to successfully liaise with the crisis team, who went in to check on the injection technique, because this was before we had the video consultations. They corrected that injection technique, and the insulin dosages went from 40 twice a day to 10 twice a day, with fantastic glycemic control. So, you know, simple things. So make use of everybody that's around us in the teams.
But the overarching there is common things are commoner.
Yeah.
Just make sure the injection technique is right. Mm-hmm. So I think whether it's COVID, non-COVID, whatever the time, make sure the injection technique is right.
And this is a policy now which is looking at, it's actually a position statement about safe discharge from hospital, because understandably in the early days there was a big push to clear the beds to get people out of hospital, and we were experiencing difficulties. So people had insulin pens but no needles. I've been on a couple of emergency dashes with needles for people. So this is a checklist process now. I think missing from here is, for those newly diagnosed, is the education that they've been signposted to education. Of course, education is not just for those who are newly diagnosed. It should be an ongoing, at least an annual event. So I think it is important that we still do that education piece. But I think one thing that is really useful to have in practices is maybe a system whereby the diabetes discharges go to a personnel in the practice that's experienced in diabetes, so that they can make sure that everything is in place. Because if they've been in hospital and they've had diabetes, then they've got that increased risk of possible readmission. And I think these people are a strong cohort that need to be followed up carefully.
Yeah, I completely agree with you, Nicola, because you've got to give some credit to the staff at the hospital, because they had to work in such a tight space of time to clear the wards. But then we need to be practicing safe medicine as well, do no harm. So kind of a checklist like this actually helps. So when they come into primary care, somebody can look at this and say, okay, you've had that, you had that, you had that, you're missing that, let's give you some more, and things like that. Like you say, if somebody's focused on it, you're going to pick it up. If it just goes through your doc man and everything, you're more likely to miss it. But there again, you talked about education. If the person with diabetes had some basic education prior to discharge, they might actually be proactively coming to the practice and saying, I don't have this.
No, education is absolutely key. And what we've been trying to do, and again, I do apologise because the last slide and this one will be difficult to read, but it's just an awareness of we have local guidelines now on how people can safely titrate insulin. Some secondary care outpatient clinics are no longer running, so it's falling on primary care to be able to titrate people's dosages of insulin where we might not have been expected to have that responsibility before. And I think it's really important that we can do this safely. And also anecdotally, we're hearing that people with COVID and diabetes are needing quite large doses of insulin when they're unwell. They're becoming very insulin resistant, and that then needs de-escalating on discharge when their health is recovering, to avoid hyperglycemia.
Yeah, because there is lots of stories about hyperglycemia in persons without diabetes but having COVID, going to hospital, started on insulin, and then how do you down titrate? How do you get them off it, or do they need to stay on it? So those are huge discussions that need to be had. That's why a good discharge process will always help primary care.
And although we have these guidelines in Manchester, if you don't have guidelines, then I think the most wonderful thing is that Diabetes UK now have an advice line, and this is a dedicated line for people that are insulin treated with diabetes, and it's staffed by healthcare professionals. So I think if you take one thing away from today, it's knowing this number, so that if you are struggling or patients are struggling with their insulin management, then this is a great thing. And where we're talking about opportunities and progression.
Yeah, absolutely. So the pandemic actually has brought up a innovative fix. Which is this. And, you know, we've had some questions on chat about insulin management in certain groups of people and things like that. That number is phenomenal. You can just ring it anytime, like you said, 9 to 6, staffed by healthcare professionals who are experienced with insulin and other diabetes management, who can give you some advice on managing the person, especially if you can't get in touch with a local specialist or GP with specialist interest, or a nurse, diabetes specialist nurse. So what about admissions avoidance? I mean, other than all the other things that we talk about, cardiovascular disease, coronavirus, everything else, these are the 4 main things that people generally get admitted to hospital with. And unfortunately, because of coronavirus, this is actually coming to the fore a little bit more. And particularly in type 2 diabetes patients, you're finding the episodes of HSS as well, where it's, the blood sugars may be high or low. I mean, blood sugars are normal, but then you have ketones in the urine. So how do we organize the ketone testing for them? And acute kidney injuries, secondary to AKI, secondary coronavirus infections, and then hypoglycemia as well associated with infection. So these are things that we are going to have to look at in primary care to try and avoid. I mean, that's built on us providing better information, which we'll talk about in a minute.
So I think it's very important then that, we're actively looking in practice where we've said that people with too tight a glycemic control are at greater risk. Are we checking, who's got a HbA1c under 48 that's on insulin, or a sulfonylurea that's at risk of hyperglycememia? Have we made sure that the medications are right according to the renal
So we'll
function?
be looking at that under the other topics.
On the other things. So those are really important things. But I think the main thing is we know that a lot of these conditions are precipitated by when people are unwell. I think it's important that we look at the sick day guidance. And I know that there's been other webinars on this subject, so we've been just asked today to cover our top 10 tips. So number 1 is rest. So people should be avoiding strenuous exercise, plenty of clear, sugar-free fluids. Over-the-counter medication for symptom relief, what would be your thoughts on that, Naresh?
I mean, there's lots of papers out there talking about NSAIDs and coronavirus and things like that. So my view would be paracetamol is the safest of the lot. I would use that. But if you feel that you need the NSAIDs for another condition that you might have, like arthritis or anything, I would suggest you carry on, but let your healthcare professional know that you're taking these therapies for this particular reason.
And then it's important we consider special groups. So we should always know our limitations. So I think if we had a sick child with diabetes, I think if we had a pregnant lady with diabetes, somebody having pump therapy, we then need to be thinking, is this our area, or do we need specialist support from this? Renal as well would be another big one, wouldn't it?
Absolutely. So I think know your limitations, do no harm.
Yes.
If you need advice, there are people out there who are willing to give you advice.
And it's important to review medication. So if we look at the next slide, we have this algorithm. It says SAD MAN, and these are the medications we've traditionally said we should stop when somebody's unwell. But what we're trying to do is we're trying to say these are sick day guidance rather than sick day rules. Because there's been a little bit of discussion around the fact that some of the sick day guidance for diabetes has slightly conflicted in which medications to stop. And I think our overall message is assess that person who's sat in front of you. So yes, we would normally say look at stopping the diuretics, but actually if that person had heart failure, that might be the best option for them. So it's very important to consider the other comorbidities and make those decisions.
Completely agree. I mean, there are therapies in there that you wouldn't stop, but I think you take the person in front of you and then they decide on their illness whether it's appropriate to stop those medications. Once you stop them, look at the time when you're going to reinstate the medications as well. And like you said, there has been a lot of controversy about SGLT2s and coronavirus, and lots of practices have searches for patients on SGLT2s and sent them text messages. And some have actually read the text message appropriately and carried on the medication until they've fallen ill, but others have just rung up and said, I'm stopping this tablet now. So I think it's important, the messaging is very important, I think.
Yeah, and how we get that across. But I think, the general message is stop the SGLT2s when somebody's unwell with type 2 diabetes, and then consider reviewing the other medications.
Yeah. So SADMAN is a good mnemonic to remember about what's the type of therapies that you need to be looking at when somebody's unwell.
And I think you've just mentioned, Naresh, that as well as reviewing medication, know when to restart it. So
Absolutely.
How many times do we see somebody goes into hospital with an acute kidney injury, 9 months later you do the diabetes review, HbA1c's gone up because the metformin got stopped, blood pressure's gone high because the ACE stopped. So do look at when to restart the medications.
And if appropriate, obviously.
Yeah, when appropriate. Never omit insulin, and certainly not in type 1 diabetes. We certainly had a case where somebody, because they weren't eating and drinking with type 1, thought it was appropriate to stop their insulin and then sadly went into DKA. And that's really important, but it's more important to monitor your blood glucose levels more regularly. You probably want to be doing that every 2 hours whilst you're unwell, if you have access to blood glucose testing. And for those with type 1, you'd want to look at ketone testing.
Yep.
And again, there's been a lot of controversy over should everybody with type 2 that's on a SGLT2 inhibitor have a ketone monitor. But that would be a big exercise to suddenly give to everybody and have that education. And what we've been working really hard at in Manchester is to make sure that all the hot hubs have access to a ketone testing monitor, plus all the crisis teams and district nurses teams that might need those. And
so
I think
people who are going to be a first point of contact for somebody who's ill, we made sure that they had the ketone testing meter so they could do that and then make a decision based on that. Like you say, if you give everybody you could give everybody a ketone testing meter, but then you need to make sure that there's education also. Is there enough of them around?
I think it's important just, if in a practice your colleagues maybe don't specialise in diabetes, just reminding our colleagues that with type 2 diabetes and DKA, it is a low risk on an SGLT2, but they might have ketones at a relatively low level of a capillary blood glucose level. They may see it at 12 or 14, whereas that would normally be higher for type 1 diabetes.
Absolutely.
And going back to education is really important because actually this was an audit that we undertook about 3 years ago, and we were asking our cohort with type 1 diabetes, what did they have access to ketone testing? And I think it was 18%, I think it was, who told me that 29%, that they didn't know what I was talking about with ketone testing. And
these are type 1?
These are type 1.
Okay.
And we had quite a few who had out-of-date equipment. So we were doing the audit at Halloween time, so I said each year it was important to remember those scary ketones and to make sure that their equipment was in date.
So I think it's important, again, we're talking about the simple audits like this, just to trying to find out. I'm sure we can do that even in the current situation. You can audit and see who's been issued a ketone meter, especially persons with type 1 diabetes. So what we thought was we're going to finish off now and just give you some practical recommendations about what we think might be useful during this time. The first thing we talked about was medicines optimization. And we talked about the SADMAN, the sick day guidance as opposed to rules, and up titrating and down titrating medications, removing therapies that are not essential, especially looking at frailty, elderly people. Do they really need to be on all those therapies? And is it causing more harm? Second bit, inertia, do you want to take that, Nikki, and talk about that?
Yeah, so I think it's just important to say, we can't have inertia. We know this is a really high-risk group of people that have either type 1, type 2 diabetes, and we haven't got time to sit back and allow more complications to develop and to happen. We have to be in there and working as much as we can to meet those needs.
Well, I would say use friends and family tests for that. If it's your friend or your family in front of you, would you say, let's just wait 3 months for this? Or were you going to get in there and do something? Things might not let you do it, but I think it's always worthwhile having in your mind that I want to look at therapies if the situation allows. and the person in front of you is happy to collaborate with you on that aspect. We talked about sick day rules already, and actually want to change that to call it sick day guidance as opposed to rules. And then we want you to reinforce lifestyle. I mean, we were just talking before as well. Lockdown has given a lot of people an opportunity to have some time to do exercise. We could all get bogged down in work, but Boris said you could have 1 hour. Now you can say as many hours as you want, but at least if you could do 30 minutes, 5 times a week at least, I think that will be phenomenal. And I was telling Nikki as well, there are a couple of studies that have come out, and one of them actually showed that in some areas, HbA1c has actually improved during this pandemic, but in other cases, such as in China, HbA1c actually worsened during the pandemic. So there's a bit of everything, but I think there is an opportunity for us to reinforce lifestyle. There is the danger that we could get into, more bad habits such as alcohol and eating more and a sedentary lifestyle. There's only so much of Good Morning Britain you can watch. So I think trying to speak to people and reinforcing the lifestyle aspect, and also, like you talked about, emotional and mental well-being. How do we support that? Are there apps that we can direct them to? Are there other services that are available through IAP services?
And then reassurance, I think that links in with what we've talked about with the mental and emotional health, and just letting people know we're open, we're here, we're available at the end of a phone, we can see people face to face if we need to. But I think I'd just like to end on one point, because we've talked about the mental health and the emotional well-being of the people we've been caring for. But I think it's very important that we look after ourselves as well. Absolutely. And certainly the Journal of Diabetes Nursing has got a great article on top tips to help us look after our own mental health. We need to be in a good place so that we can offer the best of services to those we're looking after.
It's not easy out there, but I suspect all of you are really heroes and doing the best you can. And good luck to everybody. And there ended the presentation, and we're ready for some questions.
Is there space to check in on patients' well-being in these remote reviews? We know this is key for professionals to work holistically with barriers to adherence.
So I think there has to be space, because I think so much in diabetes you are not going to achieve unless you overcome those psychological barriers or those mental health problems that somebody's having. There's no point in me doing an annual review with somebody and telling them how to eat more healthily or do more activity when they've got low mental health, low
Absolutely.
Emotional health. They're just not going to do that. So that has to be the crux of it. We're never going to achieve good outcomes unless that is addressed. So time has to be built in.
So we are looking at some documents are coming out later on trying to provide some guidance, and one of them really does include doing a quick assessment of mental health and psychological well-being, etc. So that will actually promote better management.
What are the tightly controlled high risk?
So one of the things that they found in the study was like a J-shaped curve. So it was like any other study, like a cord, etc., which showed that hypoglycemia, so where if you're very tightly controlled, is more prone for hypoglycemia, and the risks thereby increase. And that's what they found in this. That's why we're saying tight control can be as dangerous as poorly controlled.
Hi, you might have mentioned this in the first few minutes that I missed, sorry. But when you talk about poor control, what kind of measurements are you talking about in terms of HbA1c or random glucose?
So again, I'll let Nikki chip in as well. I think we're just going by what the data is available at the moment. And if you look at the data, it says you could argue anything over 58 is poor control with respect to the coronavirus situation. But if you had somebody who's elderly and frail and it's got a 58, you'd think, well, actually, that's not bad. But in the context of this pandemic, they're suggesting that anything over 58 puts you at a higher risk. It's difficult to just tell people, well, anybody over 58 is high risk. But I think you need to be wary that they're more prone to be having adverse outcomes. you agree, Nikki?
Yeah, and I think it's, it's obviously on an upward slope. So, it's starting at 58, and as we mentioned, it quadruples over 86. So, when your HbA1c is over 86. So certainly it is that higher HbA1c that maybe confers even greater risk.
Yeah.
But there isn't a specific guidance. And as I say, when that document was published yesterday, there was quite a lot of comment on social media about where do you set that HbA1c to say that somebody has poor glycemic control. So as Naresh said, if somebody was very frail, I think you'd be happy at 58. But, if it was somebody newly diagnosed, you might want to be more proactive in what you're doing.
Absolutely. So
it was young and newly diagnosed. Yeah. So I'm sorry that doesn't give anybody a specific answer. So it is just, we keep saying it, don't we? It's individualised target. It's that person in front of you. And
so quickly, Hope, what we're going to say is in Manchester, what we've done is based on this, we put out a statement to lots of practices and everything about talking about better glucose control rather than saying this is a range. So it might have a positive effect in lots of persons with diabetes thinking, well, actually, my levels are not great. I need to see the healthcare professional and do something for it. So you might find it has a positive effect, but I think we don't want to scare people and do things. So trying to improve compliance, adherence, and things like that, it's useful that we can have this information.
And I think that's a really good point, Naresh, because last week when that data was announced by NHS England, it was good that some mechanisms had already been put in place because people with diabetes were naturally anxious. So particularly people with type 1 diabetes, hearing that their risk was higher, and parents of children with type 1 diabetes. So NHS England had been fantastic they developed a document which was explaining in simple terms what hazard ratios meant. There's a group on Twitter called @Diabetes101 that's been given an awful lot of support online for people. So NHS England knew that was potentially going to be big information, and they'd made sure they'd backed it up with some help for people if they got that anxiety around it. Yeah. We have to remember that of getting coronavirus is still very low, don't we? So that's important to keep that message.
Absolutely. What about SGLT2 in type 1 diabetes?
So there was a document fairly early on, which was a position statement, which I know Diabetes UK were involved with, and I think NHS England. So the recommendation is for SGLT2 in type 1 diabetes to be stopped. So
all persons with type 1 diabetes were informed to stop their SGLT2s during this pandemic.
And people with type 1 diabetes on an SGLT2 should be under specialist care. And I certainly know that our specialist teams made sure they'd contacted those people to give them that advice. There has been 1 or 2 persons, even without diabetes, being put on SGLT2s. And again, the people with cardiac conditions who didn't have diabetes that were on SGLT2s, the advice for them is for them to be stopped as well.
Yeah.
But we can continue in type 2 as long as they've got that sick day guidance and they stop when they're unwell.
Does COVID affect type 1 or type 2 diabetes? Should they take vitamin C and D?
I'll let you answer that one.
Good question. Again, it's all very anecdotal, the evidence about vitamin C and vitamin D. I think there was some trial that didn't show much benefit in people taking vitamin D. Vitamin C, absolutely, I have not seen any trials that suggested a positive effect. But again, vitamin C, most people would take it if they had a cold, and I would suggest continue taking it. It's not going to harm you. And if you're on the low levels of vitamin D, actually required therapy and probably would benefit. So if you've got normal levels of vitamin D, and there's no point you taking vitamin D.
What questions would you advise professionals to ask when having conversations about mental health?
So there are a lot of questionnaires available for us to use. One is the simplest one that we all use in primary care, is called the PHQ-9. And there's another one called DDS-2, which is only 2 questions and is very straightforward, that can be put to patient. It's almost like how are you feeling? have you had any bad thoughts and things like that. Just very simple, straightforward, that then leads you on to further deeper questioning. So these are available on websites. So it's called the DDS2 and the PHQ-9. I'm sure all GPs and nurses online would know what a PHQ-9 is, and this is one of the standard ones that we use. In our practice, we used to provide that to the persons with diabetes prior to a clinic, so they can fill it in, and if they reached a certain score, they would be booked in to see one of the doctors, just so they can have a further discussion about their mental health.
Yeah, and I think what's interesting is the document which has been produced for the Journal of Diabetes and Primary Care. They are suggesting that before you undertake that remote review, that you do send a questionnaire to the person with diabetes, so that they can send that back with some of the details. So it'd be useful to add in those questions. We also did the World Health Organization 5 wellbeing questions we've used as well. And then that information can come back ahead of the consultation, and it just gives that person a bit of time to think about it and fill it in, rather than, you know, just being asked on the hoof, so that could be useful as well.
Quickly, Hope, I mean, to anybody out there who's interested, there is a small study going on with the Professor Catherine Barnard from Southampton. They're doing a study about mental health in diabetes, and it involves sending out a link for a questionnaire. So it comes back to you, and it kind of gives you an assessment about their mental health and also what they want to get out of a diabetes consultation, whether it's face-to-face or remote. So if anybody's interested, if they want to send me their details via you, I can link them in and send them this so they can try it out and see how it helps them, because it gives the person with diabetes an idea about what knowledge they're lacking, what do they want to know, is it their mental health, financial problems, whatever. So it gives you a good idea about that. So we're going to try that out. Nikki doesn't know this yet, but we're going to do it.
Sounds great. Should vulnerable type 2 people be at work in an enclosed office space?
Great question.
Yeah, and there is going to be, people need to be watching this space, because there's going to be a position statement very soon from Diabetes UK relating to this. And it is important. At the moment, the advice is to social distancing for people with type 1 and type 2 diabetes, unless they have another condition which puts them in the shielded group. But certainly off the back of the data we've discussed today, that was produced by NHS England last week, that data has gone to the Chief Medical Officer for them to review where diabetes needs to be placed. So it's a very hot subject at the moment. And I think that there will probably be, you know, even now there is a call to make sure that employers can ensure that people can be correctly socially distanced at work. And certainly we've seen an increase in people with type 1 diabetes that are teachers asking us for advice over the last couple of weeks about going back to work. But do please watch this space, because we will be getting a little bit firmer advice and guidance on that.
Yeah, no, I completely agree. So there's been a lot of confusion. There's social distancing, there's self-isolation and shielding.
Yeah.
So the type 2 diabetes don't fit into the shielding group. So they could fit into the self-isolation if they're poorly controlled and all these things, but nobody's actually said what is the level that is poorly controlled. So I think, like Nikki says, some specific guidance is going to come out. Ideally, the thing we'd say is social distancing is the norm there.
Which patients are you seeing in groups?
So I personally haven't done a group consultation, but some of my colleagues across the country have. So some of my dietetic colleagues have been doing group consultations for women with gestational diabetes that have been working very well. Some of my practice nurse colleagues have been doing some group consultation for people with type 2 diabetes. And I am aware, not specifically group consultation, but there's consultations on Zoom that involve other people in relation to the National Diabetes Prevention Plan. And as I say, these are, you know, not just providing education, they are really helping with social isolation and company.
I think group educations are useful if you have a well-motivated patients, persons with diabetes, and I think they're suitable for certain types of things like group starts of GLP-1s. But again, you've got to have a motivated person and willing to technically able to connect in that sense.
Why are type 1s more at risk of COVID complications?
Obviously they have it's to do with how the diabetes itself. So if they have an autoimmune condition that is causing the diabetes, they're more at risk. Obviously, you'd think, well, the immunity is dropped and things, and they probably tend to have it for longer as well because they've had it since birth. So, and then generally the control in type 1 diabetes is not as good. Would you agree?
Well, I think it's variable, isn't it? You know, so I don't think we could make that generalisation, but I think, like you say, it's a lot to do with the fact that type 1 is this autoimmune condition, and
it's more to do with that than the control. So because I think it's had it for longer, and also the fact that the autoimmune condition are more prone to getting the issues, and cardiovascular disease can also occur quite quickly in them as well. So I think there's a lot of renal issues can happen. So they kind of fit a whole plethora of risk factors.
What's actually interesting, if you look at the numbers of people, you know, just at the actual cold number, there's less people with type 1 diabetes have had an adverse effect. But when you look at it as a percentage of the type 1 population, that's where the risk then becomes higher, because there's obviously more people with type 2 diabetes. So it's all to do with those hazard ratios.
Okay. You mentioned about not needing to take vitamin D unless it's low. Do you routinely check vitamin D levels, and are there any particular groups you check?
Obviously, no, we don't routinely check, although there was a drive in Manchester looking at vitamin D levels in Asian population and whether that had an effect on HbA1c. And long term, there was not much benefit, but we don't routinely check them on an annual review. If you are particularly concerned, it's more common in Asian people. So I would check in an Asian person. You know, they usually complain of lethargy, tiredness, and things like that, which is not related to anemia. So you might want to check in that. But whether it has an actual influence on HbA1c is debatable.
What platform is being used for groups?
What platform?
Yeah.
I think any platform. I mean, anything that is easily accessible. So Zoom is good as any, but I think there have been issues around security that we've been talking about both nationally and internationally. I think the general accepted thing is Microsoft Teams. That's what NHS has acquired for most people. And in primary care, again, we haven't done AccuRx type thing, but it mainly tends to be Teams and Zoom at the moment. Skype, again, another option. It all depends on what's available and what the patient can access.
And I think it's also important, you know, just to make sure, you know, don't just go off on a tangent now this afternoon and do a group consultation without just checking with your trust or your CCG that, you know, just check around the data protection. And certainly when you're doing remote reviews, you've always got to get the consent of the person as well, and let them know that it is, you know, how we are recording it, potentially. So it is important that you do just check all your data protection and that you've got permissions to do it.
And there is guidance on how to do a remote consultation, just a virtual consultation, which actually requires you to get consent, make sure confidentiality, who's in the room with the patient, who's in the room with you. So there are a few guidelines that you need to follow before you do a remote consultation, be it for diabetes or any other condition for that matter.
And again, the document which we've talked about with the how to do the remote review, that's got the references into those to what you're referring to. So, yeah.
How can we reintroduce SGLT2 in patients who have started on insulin and are advised by specialists to switch back to SGLT2 safely?
Okay.
So they will be on the spec. So if it's the type 1s that are being told to stop taking it, then they need to remain under the care of the specialist. It's not for primary care to be managing type 1 and SGLT2s. That is part of the guidance with them. So that would be the decision of the specialist.
Absolutely agree. So I mean, obviously, I sit in the confluence of primary and secondary care, and I completely agree with you. I think that group of patients should be with the specialist, and once they feel that there's a risk is low enough for them to initiate, and they can keep in touch with the patient and make sure they're monitoring ketones and all things, that's when I think they would start it. But I wouldn't start it in primary care unless I've been given specific instructions by the specialist to say, please start this one. I will monitor this patient. That's what you need.
And I think in type 2 diabetes, where somebody's had their SGLT2 stopped, it's important just to check back, make sure that wasn't for a DKA admission, in which case you would never restart it. And you would want to restart it when you knew the kidney function was adequate, that they were eating and drinking well, that their signs of infection had cleared. So that's where you would wait to restart it.
And they understand the sick day guidance.
Yeah.
So final question, do you have any advice for people struggling with good diets where they might be relying on food parcels from the government and can't rely on priority shopping for financial reasons?
I'll take this one. Yeah, because interestingly, I'm dealing with somebody at the moment who's living in a hostel, and he keeps getting delivered food which needs a cooker, and he doesn't have a cooker. So he is really struggling and hasn't got money to buy his own food. So it really is difficult, and I managed to get one of my dietetic colleagues, to contact him yesterday, but it is very, very challenging because he's on insulin as well. And certainly when he's had his insulin, he doesn't always know what food's going to arrive. So it is really difficult. There's a group in London, and again, I can provide you with the details, that have done some really useful resources for people who are relying on food banks, for people who are living in hostels, for people who don't have access to cooking facilities, because this is, very sadly, this isn't an uncommon problem. Yeah. And also even for some of the people that I'm looking after who aren't in hostels and so forth, some of them that are in the shielded groups, they've really struggled just to get somebody to go out to do the shopping. But again, this wider community group, who I say are sending me these emails every couple of weeks, have managed to put me in touch with some local organisations that have managed to help with that. So it's that reach out.
I think it's a dreadful situation. Yeah. The pandemic has caused so many problems, and then people are saying, "Oh, I got diabetes, but I got to live as well." And I'm living off people giving me food. So what can I do, or what do you want me to do? So I think it's important for us to try and find some way of helping these people, providing some guidance. Okay, if you're eating this, what can you do to mitigate that? Is it a little bit more exercise if they can take that? Or get them in touch with the UK, see what other advice they can give them. So those sort of things. I mean, what can they do differently with the food that's been delivered? Is there something else they can try? So they need advice, need help. I mean, there's no clear answer for that, but I think it's important that we're there for them and empathize with them, and just not say, well, don't eat that. But no, the food is available. So it's a distressing situation, and I completely feel for the person who asked me the question as well, asked us, because I think you can only do the best you can and support them. That's it.
And I'm finding it incredibly challenging myself at the moment with this gentleman. I think he appreciates that I'm phoning him, to help him. Yes, I am finding it challenging myself as well. But he appreciates that contact, and we're trying to do the best we can with looking at carb counting as well. But I do empathise completely. It's very difficult, and there's a lot of very vulnerable groups out there.
Be there for them, heroes, all of you.
Absolutely. So on that note, I'd just like to say thank you both so much. It's been really, really interesting and useful session.